In this segment, we're going to speak to Professor Anthony Figaji, I hope pronouncing that properly, who has won an award, Harry Oppenheimer Fellowship, which looks into the questions of brain brain damage, brain conditions, severe brain conditions in children, traumatic brain injury, and the central nervous system infections such as bacterial, tuberculosis, meningitis, using real-time brain monitoring and direct sampling of cerebrospinal fluids. She knows how to treat brain injury, central nervous system infections using real-time brain monitoring and direct sampling of cerebrospinal fluids. Yeah. I'm joined now by Professor Anthony. Welcome to Power Talk.
Thank you very much.
I hope I didn't butcher your surname, Prof. Is it Figaji?
Yeah, you did a great job.
Thanks. Very nervous there with names. But thanks very much for creating time here on Power Talk. And my congratulations on the Harry Oppenheimer Fellowship.
Yeah, thank you very much. It's indeed an honor.
Yes, if you could just take our listeners into confidence, what does this award mean?
Well, firstly, it's a great honor. It's a prestigious award. The Harry Oppenheimer Fellowship is well known in academic circles or science circles as kind of one of the prestigious awards because it's highly competitive, and every year there are the best scientists in the country apply for it. So being awarded it, of course, is an incredible honor, and it's a validation of all the things that we really believe in and have worked very hard to achieve.
And what has then inspired your research and academic focus on pediatric brain injury, particularly in Africa?
Well, it stems from the clinical work that we do. So I work at the Red Cross Children's Hospital, and I work in the neurosurgery department. And I've been working here for a very long time, and over the years, we just see an unbelievable number of children who die or are disabled by conditions that are either completely preventable or at least treatable in the sense that you can make a meaningful difference in their outcome. So it's not just about surviving or dying. It's about surviving but without a permanent disability. And most of the conditions that we see, and there are lots of conditions that affect the brain in children. Traumatic brain injury is one of them. Meningitis is another. Stroke, epilepsy, conditions called hydrocephalus or water in the brain. And most of them, at least in children and young adults, are completely preventable. And we don't do a great job as a society or as healthcare systems to prevent it. And I think we should also do so much more in terms of just treating it better as well.
What constitutes real-time brain monitoring in children? What does that look like?
So the problem with brain injury, so obviously if you can prevent it, it would be preferable, right? So in children, the majority of the severe injuries to the brain are due to road traffic accidents, the vast majority. And that's completely preventable, of course. About half of them are children who are injured as pedestrians, and half of them, just less than half, are children who are injured as passengers in the car. And of the passengers in the car, just for an example of how you...
And what ages are we speaking about? I mean, just to put it in...
Across the full age range. So children, infants who are in cars, who aren't in a car seat or don't have a seatbelt, and the minority, that's the crazy thing, the minority of children who are being transported on the roads in personal vehicles, they do not have a seatbelt on.
Wow.
And that makes a massive difference. Of all the children that come into our unit when they've had a severe head injury, that means they're in a coma due to the injury, and they were a passenger in a car, only 4% of them were wearing a seatbelt. And so a big part of our campaign is just to get people to wear seatbelts, like a really, really simple intervention. And it's actually the law. Right? So it's the law of the country to wear a seatbelt for all children, and we just don't police that at all. And so that's the one message that we want to get across. And seatbelts is just an example of it. There are so many things that we can do to prevent injuries to children. And these injuries to children are devastating, and they unbelievably common. But then we also recognize that we're never going to be able to prevent all of them. So the other focus of our group is that we want to do a better job treating them. And the reason that where the monitoring comes in is that whenever the brain has an injury or there's some kind of insult to the brain like stroke or meningitis, that injury or that insult sets up a whole bunch of chemical processes in the brain that play out over the next hours or days after the injury. And those chemical processes give rise to brain swelling or electrical discharges in the brain or things that injure the brain. So that injury actually continues over the hours and the days after the injury. And that continuation, we call those secondary processes, that worsens the outcome. So that doubles or even trebles the risk of dying. And so the idea of our monitoring, it's very advanced monitoring of the brain, is to try to pick up some of those processes that are happening and intervene before it causes ongoing damage. And if you can do that, then you can improve the chances of them surviving it. And not only surviving it, but surviving it preferably without disability.
How long, I mean, for let's say one was involved in some form of accident, but it was not fatal, it was not as bad, and one cannot immediately see the injury because maybe there's no fracture, there's no blood and all of that. Does a normal, ordinary hospital checkup, is it capable of detecting that there could be, like in the emergency wards across the country, are they able to pick up that maybe you need a bigger, more focused brain scan or something? Is that service there in our hospitals?
Well, to answer that properly, you have to understand that there's a continuum from somebody who has a very mild knock to the head. If you walk into a door, you can be momentarily stunned, but there's not necessarily any permanent injury done.
Yeah.
And there's a continuous spectrum from that really mild end of the spectrum all the way through to people with devastating injuries to the brain. You know, you involved in a massive car accident and you get flung out of the car and your head crashes against the tarmac. So that would be at the severe end of the spectrum, and that patient ends up in a coma, for example.
Yes.
The problem with that spectrum is that the majority of head injuries cluster on what we would call the mild end. Now, when you're at the mild end, and people talk about concussion, so concussion is an example of a mild injury. The majority of people who have a concussion, they will recover from it. Some of the people who have concussion still have symptoms that linger on, sometimes for weeks, sometimes for months.
Could they be for years?
It's very difficult sometimes to pick up what's causing that, because usually the scans that we do are not really sensitive enough to see that level of dysfunction. So the normal CT scan, for example, is very often normal. Sometimes you can do an MRI scan, and that's a little bit more sensitive, but it's more expensive. And even MRI scans might not always pick up the injury. So it's not always straightforward. We definitely do scans, but the key thing is whether people still have symptoms related to that injury or not.
But Prof, could they take years? I'm thinking about injuries that come, which you didn't mention, that come from children falling from bed, or children falling from the hands of their caregivers, maybe because the mother is drunk or the caregiver is drunk, and they've got a head injury. And what I'm trying to get is the spectrum, this sort of could the injury go on for years and years and years until a person is maybe a teenager and they are suffering from some symptom from an injury that happened in childhood?
Sure. So I think there are two parts of that I would answer.
Mm.
So one of them is yes, you can have an injury and maybe or maybe not they get taken to a hospital, and maybe or maybe not the injury is diagnosed.
Mm.
You know, sometimes say, well, we didn't really pick up an injury because they weren't looking for some of the subtle signs. And so maybe that injury is missed. And then one of the common things that happens to children after an injury, especially on the mild end of the spectrum, so this is easily missed, is that the commonest consequence of that is what we would call behavioral disturbances.
Mm-hmm.
And a really common behavioral disturbance is hyperactivity.
Hyperactivity.
Yeah, so they just pay a little bit less attention. They struggle at school, and then they go on and on for years and years with in our school situation, usually with nobody who is there to assist them, to give them additional assistance. And so they start failing at school, and largely because they're just not being able to pay attention. So there are those kinds of subtle things that can happen after a head injury that often aren't picked up immediately by the healthcare services. That's the one thing. And then the second thing is there's a concern, and it's very, very difficult for us internationally to get our heads around how much of a concern this is.
Yeah.
But it's particularly revolving around the sports arena, and this is why everybody's anxious about getting concussion on the sports field, and that's why rugby and even soccer is taking it very seriously, the head injuries or concussion that might happen
boxing.
on the sports field.
What about boxing?
And boxing, I mean,
yes.
that's the obvious one.
Majority of our concussions is boxing. I mean, I'm imagining school ground fights where the kids go on a school ground and they start fighting.
That's right. And so that's in fact where the original concern came from boxing and people like Muhammad Ali, who developed what are called neurodegenerative diseases like dementia or Parkinson's, but many, many, many years after the fact. So the concern is that a concussion, especially repeated concussion, can set up these processes of inflammation in the brain that are quite subtle, but they play out over years and potentially could increase your risk of developing dementia or that kind of condition in adulthood.
So we could be having adults going around here with some injury in the head from falling in childhood with their head, or being punched in the head, or some form of...
In theory, yes. I don't want to cause panic, of course, because not every cause of dementia or not every problem in life is due to something that happened many years ago. The important thing is to recognize that it is a possibility. It doesn't necessarily mean that if a child is failing at school, it's due to them being dropped on their head as an infant.
Yeah.
So the majority of those kind of mild injuries, they do recover from, and to the best of our knowledge, they recover fully.
I see.
Whether they are going to have long-term symptoms or signs may be a combination of several things. Has it happened more than once, for example? And also we think that there may be some genetic vulnerability. So some people genetically may be a little bit more vulnerable to the effects of an injury than somebody else. So yes, there is the possibility that these relatively minor knocks to the head can have more significant consequences than we think, but let's not completely panic, so that not every mild head injury
Yes.
is seen as something to worry about or explains some behaviors several years down the line.
So this ability to monitor inflammation and drug penetration directly in the brain is not a very common thing. It's rare globally. And I thought I might ask the implications then on administering, implications for drug designs, your dosages,
Yes.
things like clinical trials,
Exactly.
especially for the continent, which is already a resource frustrated, resource scarce community.
Yeah, absolutely. So this involves patients. This is true for children and adults who are on the more severe end of the spectrum, who have to come into hospital for treatment. Very often we give them medication or drugs, and it might be drugs for epilepsy, maybe drugs for sedation. It could be anything. The problem with giving drugs for a brain condition is that the brain has these protective mechanisms to keep drugs out. So that's the way that the brain protects itself against any toxic substances getting into the brain. It's called the blood-brain barrier. So the vessels of the brain have these special protective capabilities of keeping the toxic substances out, including drugs. And so getting drugs into the brain, firstly, that's difficult. The second thing is it's also very difficult to determine whether the drugs actually gotten into the brain, because the brain is a very difficult organ to examine. So we've got a few techniques that we've developed over the years to try to overcome our inability to see inside the brain, and in particular to determine whether the drug's actually getting into the brain at the concentration that we're trying to get.
And this is what your research will be able to answer?
Yeah, so at least in part, we anticipating that we're going to be able to advance our understanding of how drugs get into the brain and what determines the concentration, how successful we are. And as from that, we want to develop general principles that help us understand how to get drugs into the brain, again, wherever you are.
Yeah.
And that's where the recognition of the resource constriction or resource limitations across the world are important. Not everybody is going to have the capacity to actually monitor whether the drugs are getting into the brain. But if you develop a better understanding of the principles of drugs in the brain, then you can try to predict what will happen whenever you don't have that kind of monitoring capacity.
God, I don't have enough time to get into that. But what implications? I'm thinking, what kinds of assumptions will you be challenging in pediatric critical care across the world? I'm thinking this is basically you're going to be at the center of an international research initiative that is quite frankly not taking place across the world. But what assumptions will you be undermining and challenging in relation to practices in pediatric critical care?
So there are several that we hope to challenge. I'll give you one example. When we treat meningitis, for example, tuberculosis is really common in South Africa. Really common in South Africa, really common in India, many low and middle income country places. The way that we treat the condition is with drugs that we've been using for the last 40 years or so. We haven't made a lot of progress in using different drugs or thinking about how to get the drugs into the brain. So when TB involves the brain, it's called TB or tuberculous meningitis. And it's the worst form of tuberculosis. It has a very high risk of dying, and it has a very high risk of leaving children and adults with stroke. The problem is that happens even when we give them the medication to attack the TB. So they've come in, we've made the diagnosis that there's TB in the brain. We give them the appropriate drugs, but very often they still continue to deteriorate and sometimes even die. And so our contention is that the drugs actually aren't getting into the brain at the concentrations that we need. And we need to have more effective drugs. So our assumption is that the assumption that we want to change is that over the last 40 years, we've been doing the same thing, and the outcomes are bad. Oh, this is not just unique to South Africa, it's all across the world.
Yeah.
And we should be doing better. And we need to do better by changing the dosages of the drugs that we give, the way that we give the drug, and which drugs that we give. And we have to shake up the field because we've been doing the same thing for the last 40 years, and the outcomes haven't improved significantly. So we need to do something different.
Okay, 30 minutes is never enough. But Prof, because you're a neurosurgeon, I always had a big statement I've heard people make. And before I let you go, with an alcohol abusive society like ours, can you tell the listeners at what stage of human life does the brain stop developing?
That's really interesting. That's really
because
interesting.
Alcohol with a consistently developing brain gets affected, I imagine. But when does my brain stop developing?
Well, I think there are two ways of thinking about brain development. So one of them is the physiology of the brain, like the anatomy and how the cells in the brain work. And that continues developing, in fact, until your early 20s. So I often make a joke to people who have children, especially who have teenagers.
Yes.
Who say that their teenagers think that they know everything in the world, like every teenager does. I used to when I was a teenager. Used to be able to tell them, relax.
Your brain is still developing.
Your brain is still developing, exactly. But then there's another aspect of brain development where it's not the physiology or the cells that change. We become wiser. And that's from experience, and that's part of our cognitive processes. And that continues far into adulthood. And we hope that wisdom continues well into your sixth and even seventh decades. The problem, of course, is that we do expose our brains. We don't look after our brains.
And alcohol is a danger to the brain.
And alcohol is one of them. Absolutely.
Isn't this grounds to increase the age of alcohol to 21? Isn't that good grounds? Yeah.
So the problem with that is, and firstly, I must say that's well above my pace. That's well above my salary grade. Because the problem is that in the US, the age restriction is 21.
Yes.
But people find a way.
Yeah, they defy.
I think it's about creating a society where we teach our children better. Because if we just ban something, they almost become more attracted to it, and they find a way around that.
Yeah.
But it's very clear, though, that alcohol is a major problem in our society, not only for healthcare in general, but for trauma. And so one of the things that we saw during the pandemic, I don't think anybody was a massive fan of lockdown, at least for as long as it lasted. But what we did see during lockdown is that the trauma rates in the major hospitals, like here at Grooteskier and at Baragwanath, the trauma rates just plummeted. And that was because people weren't getting drunk and fighting with each other. People weren't driving drunk. It's a massive problem in our society. Not alcohol itself, but the abuse of alcohol.
Yes. Okay.
So we know the impact that it has on our society. We just don't know or aren't sufficiently motivated to do the things that we do know to change that. But yeah, you're absolutely right. As individuals, we need to take responsibility to look after our brain, and alcohol is one of those things that we can change.
Well, my congratulations again, Professor Anthony Figaji, Professor and Head of Clinical Unit, Paediatric Neurosurgery at Red Cross War Memorial Children's Hospital. Thanks very much for creating time to speak to us, and looking forward to the explosive findings of your research.
No, thank you very much. And thank you again to the Harry Oppenheimer Foundation. They are incredibly supportive of science and social impact in South Africa.
Thank you, Prof.